to join. And I'll start sharing the interest slides for.
Well, welcome everybody, and hope everybody had a nice Thanksgiving break. N3Community Forum, recorded as always. Q&A button or to post a question or raise hand to unmute your microphone. Next slide. And so Enclave is seeking feedback on tools and prioritizing future improvements. So please, the short survey for any feedback or ideas be greatly appreciated. And there's a link here, and there it is. Okay, so if you could do that, that would be fantastic. Okay. Okay. Oh, so it will be posted here. Okay, you're putting it in the chat. Perfect. Okay, so the Enclave and N3C marches on 8.2 million COVID positive cases, 82 sites, and so forth. Next slide. So so in December 11th, we're going to hear from Peter Leese about CMS and EHR data examples. And next slide. But our feature presentation today is Amanda Vinson, who's going to be giving actually talk I'm looking forward to involving HRT and COVID-19 outcomes in solid organ transplant recipients. And it sounds like some really interesting work. So I'm looking forward to hearing about it. And so you're going to share your screen, Amanda?
Sure.
Great.
Uh-oh, hold on. Oh no, sorry guys. What is happening here? Sorry for this hiccup. For some reason, it's not on my screen.
Okay, link to the survey is in the chat.
Just to remind, it's about the Enclave seeking feedback while Amanda is working on that.
All right, can you see the screen?
Yeah,
we can.
Okay, sorry about that hiccup, you guys. Okay to get started then?
Yeah, please do. Thanks.
So thank you so much. I'm absolutely very honored to be here today. My talk's entitled Hormone Replacement Therapy and COVID-19 Outcomes in Solid Organ Transplant Recipients, and we're looking at this compared to outcomes in the general population. I do have disclosures shown here, but they're not relevant to the talk. So just a bit of background to start. We know that women, at least in the general population, have better outcomes after COVID-19 diagnosis than do men. This is data from early in the pandemic, looking at case fatality rates in 38 countries. And you can see that despite equal infectivity rates in all of these countries, there is a higher rate of case fatality in males versus females in 37 out of the 38 countries. There's a number of reasons why that might be related to either biologic sex or differences in gender. Here I've highlighted some of the factors that might lead to an increased risk in males. The green squares are beneficial, the red squares are harmful. So from a biologic sex perspective, we know at a fairly simplified level that androgens are overall immune suppressing. Males generate reduced have a reduced antibody response to SARS-CoV-2 and reduced viral clearance. And they also suffer more from dysregulated innate immune response and increased risk of cytokine storm as a result of this. In addition, males typically at a population level have greater comorbidity burden that might put them at risk of adverse outcomes after COVID-19, but they do benefit from better PPE fit. If we think about this from a gender lens, men, again, at a population level are more likely to be smokers and are less likely to follow behavioral precautions that are outlined by guidelines. On the flip side, if we look at biologic sex in females, we know, again, a bit of a simplification, but estrogens typically are immune stimulating. We know that the vast majority of immune genes reside on the X chromosome, and on account of incomplete X inactivation, there's a greater representation of immune genes in females than males. Females have increased antibody response to SARS-CoV-2 and subsequent increased viral clearance overall, but they're disadvantaged by less appropriate PPE fit and are more likely from a gender lens to be frontline healthcare workers and be exposed to the virus. So this is, at the general population level, but my talk is about solid organ transplant. And we know that transplant recipients are typically on immunosuppression. They have a greater comorbidity burden than the general population overall. And both men and women are more likely to adhere to behavioral precautions. So if we take these sort of different elements out of the equation, the question about differential risk in transplant patients becomes a little bit less clear, a little bit more foggy. So based on earlier work that our group has done using the N3C, we actually wanted to explore this. So we did a study looking at the risk of a major adverse renal or cardiac event in the 90 days after COVID-19 diagnosis in the general population, and then compared that to risk in the transplant population. And here we were looking at differences by sex. What you can see very clearly is that in the non-solid organ transplant population of about almost 2 million people, there's a clear decrease in risk for female patients versus male patients. And that's actually most pronounced in younger age cohorts. If we look at the solid organ transplant population for comparison, though, about 11,000 patients, what you can see is there's a pretty stark difference. So we lose that benefit of being female in the transplant population, and there's no trend or no association with changes in age. Now, of course, the confidence intervals are wider. This is a much smaller population, but even if you can account for kind of those longer confidence intervals, it does not look like the point estimate is as extreme as what's observed in the non-solid organ transplant population, with the benefit being so pronounced in females versus males. So to look at this in a little bit more detail, again, in this earlier study that we did, we looked at a number of outcomes. So we looked at, again, MARS, or major adverse renal or cardiac event. We looked at mortality, MACE, or a major adverse cardiac event, acute kidney injury, and then severity of COVID-19, which we defined as need for hospitalization. Again, we looked at this in females versus males in the non-transplant population, and then compared that to the signal that we saw in the transplant population. And this picture speaks for itself. You can see very clearly that females are lower risk for each of these outcomes in the 90 days after a COVID-19 diagnosis than are males. Interestingly, if we look at the solid organ transplant population, again, a much smaller population, you can appreciate that the risk of the benefit of being female is fairly attenuated, with the only significant benefit of being female for the outcomes of MARS and mortality, where females are slightly lower risk than males. Again, obviously the confidence intervals are wider, the population's a lot smaller, but I think if you look at the picture, you can get a sense that even if we had a bigger population, the point estimate does not seem to be as in favor of female sex as it is for the general population. If we take this one step further and we look at sex and age stratified analyses, this is again looking at the same 5 outcomes: MARS, mortality, MACE, acute kidney injury, and COVID-19 severity in the general population. What you can appreciate is very clearly there's an increased risk within every single age category in males versus females. That's true for every age category except young males and females and the outcome of hospitalization or COVID severity. But for every other outcome in every other age category, males are higher risk than females. And what you can very clearly appreciate is that there's a significant increase in risk with advancing age. They say a picture's worth 1,000 words, and I think that's true. Because when we look at the solid organ transplant population for comparison, what you can appreciate immediately is that there is actually no increased risk in any one age category with male versus female sex. And although there is a slight trend towards increased risk with advancing age, it's clearly very attenuated compared to what's observed in the general population. And if you look at the hazard ratio along the x-axis, you can see that on the solid organ, that in the general population, we have hazard ratios going up to 20. And in the solid organ transplant population, hazard ratio only goes up to 8. And if we highlight the greatest risk, it's in the setting of a male who's more than 65 years of age relative to a male 18 to 45 years of age. And you can see that the hazard ratio for mortality after COVID diagnosis in the general population is 17.4, whereas it's only 5.8 in the solid organ transplant population. So just to kind of round out what I'm telling you, a quick look at organ-specific risk. So this is looking at outcomes after COVID-19 diagnosis, females versus males. So the reference category here is male. And we're looking at those same 5 outcomes: MARS, death, acute kidney injury, MACE, hospitalization. And in this situation, we're actually also looking at rejection. And we're looking at the risk in females versus males within each organ type: kidney, liver, lung, and heart. It's a bit of a busy slide, but to orient you, ultimately, there is no significant heterogeneity for any outcome. The greatest difference between organ types was for the outcome of death, but that did not meet statistical significance with a p-value of only 0.076 for heterogeneity. And ultimately, the pooled risk was slightly lower in females than males for all outcomes is when we pool the organ-specific risk, except for hospitalization and rejection. And this was driven largely by differences in sex-based risk in kidney transplant. Okay, well, why is this? So if we think about the age-based COVID risk, there's something that's really important. It's called inflammaging. So this is defined as a decline in adaptive immunity, so sort of that focused immunity or focused immune response, and an increased dysregulated activation of the innate immune system with advancing age. So many of the physicians on the call may understand what I'm saying, but for anyone who is not a physician, just to highlight the fact that this dysregulated activation of the innate immune system is sort of like an overfiring of your immune response in response to a trigger of some sort. So for example, SARS-CoV-2. This is associated with an increased risk of cytokine storm because the immune system just goes completely crazy and ultimately multi-organ failure and COVID-19 related death. So if we think about men and women over the lifespan, in earlier kind of reproductive age and below, there's an increased immune response to SARS-CoV-2. And this leads to asymptomatic and typically mild infection in younger adults and children. In older adults, there's this inflammaging leading to increased dysregulated immune response to SARS-CoV-2, which can lead to an increased risk of ARDS and multi-organ failure. Interestingly, inflammaging is more prominent in older males than females, so that when we look at this, the benefit observed in the younger cohort, it's actually most pronounced in females. And if we look at the harm, this kind of increased overfiring of the immune response in older adults, it's more hazardous or more harmful in males. So in the general population, I've showed you that sex differences are most pronounced in the youngest age strata, followed by mid-age and finally by the oldest age group. Although we don't see a lot of sex differences or any major sex differences in those with solid organ transplant. But whenever we see differences by sex that vary by age, we need to think about the potential role of sex hormones, because we know that sex hormones change over the lifespan. If I'm telling you that estrogens are immune stimulating, and because of these kind of increased focused immune response to SARS-CoV-2, there's better viral clearance, it's probably not fair to compare a woman at reproductive age whose estrogen levels are at peak to a postmenopausal woman whose estrogen levels are very suppressed. Likewise, if I tell you that androgens are immune suppressing, which I've already alluded to in an earlier slide, again, it's probably not fair to look at younger males whose testosterone levels are at peak to post-andropause status where testosterone levels are suppressed. But it's actually even more complicated than this, because you might think, okay, androgens are immune suppressing, so wouldn't low androgen level be a good thing so that you have less immune suppression? But remember, because of this inflammaging picture, in older adults, that's where we start experiencing this dysregulated immunity. So actually, androgens are immune suppressing, and as the androgen levels go down, it's almost like you're taking your foot off the brake, and you're allowing for this increased dysregulated immune response with increased cytokine storm, increased multi-organ failure. So it's clearly very complex. So I just showed you this slide. I just want to highlight the fact that in younger adults, the benefit that's observed in females preferentially over males is likely or potentially on account of increased estrogen levels in this population. And the harm that's observed in older adults may be on account of declining testosterone, leading to, again, that foot coming off the brake and allowing that dysregulated immune response to just go wild. So I've showed you this slide, but if you think about what I'm telling you, it's sort of natural to then question, well, what about the role of hormone replacement therapy in this higher risk population where estrogens lead to this better kind of optimized, focused immune response to SARS-CoV-2, and testosterone can maybe dampen down that dysregulated inflammation in response to COVID. So we asked ourselves two questions. Does HRT or hormone replacement therapy use protect against severe COVID-19 in the general population? And secondly, does HRT use protect against severe COVID-19 in transplant recipients who are immunosuppressed? We hypothesized that we would see a benefit with HRT use in the general population on account of, again, giving back that estrogen, which is beneficial to the immune response and giving back that testosterone, which helps dampen down that catastrophic immune response and cytokine storm. But we also hypothesized that we would see an attenuation of benefit with HRT use in transplant recipients, given the attenuation of sex hormone-based risk observed in transplant recipients versus the general population, or at least what we speculate is sex hormone-based risk. So we were incredibly excited about this study, and we started off with our analyses, which were fairly complex. And while we were doing it, no one had looked into HRT use in COVID-19, but while we were doing it, we were a little bit disappointed to see a BMJ publication come out that showed the exact thing we were hypothesizing, that in the general postmenopausal population, females who received exogenous estrogen supplementation had a substantially lower risk of death after COVID-19. So an odds ratio of 0.47, which was significant for reducing the risk of, or for reduced risk of mortality after COVID-19 diagnosis. So this was a really interesting and exciting study. We were a bit disappointed because it's exactly what we had been working on as well. I'm happy to say that our paper was published in AJT in April 2023. And now I'll switch gears a little bit and go over the paper itself, the study itself. So the study was designed to examine peri or postmenopause or andropause females and males aged greater than or equal to 45 years. 45 years is not typically what's used to define postmenopausal status or post-andropause status. But because when we looked at older age cut points, our numbers got a lot smaller, we were a bit obliged to be liberal with our age threshold, but we'll come back to that. We examined those with the first diagnosis of COVID-19 between April 1st, 2020 and July 31st, 2022. We censored patients at reinfection and required a minimum follow-up of 90 days. COVID diagnosis was based on a positive test result from PCR, antigen testing, or diagnostic codes. And our primary analysis examined COVID-positive solid organ transplant recipients with either a kidney, liver, lung, heart, or pancreas transplant. And then as a comparator, we repeated our analysis in a non-immunosuppressed cohort. To define non-immunosuppressed or non-immunocompromised patients, we excluded patients with autoimmune rheumatologic disease, prior bone marrow transplant, HIV, multiple sclerosis, or malignant neoplasm, in addition to any patient with a record of taking an immunosuppressive medication. And we've done this in earlier studies as well. The exposure of interest was sex-specific HRT use in the 24 months preceding COVID. Again, here, ideally, we would have liked to use a shorter time interval, but as we narrowed the time period that we allowed HRT exposure to count as our exposure variable, our numbers got smaller. So here we used a 2-year look back, and we defined exogenous systemic estrogen and or progesterone supplementation in females or exogenous testosterone supplementation for males as our HRT exposure. The primary outcome was MARS, again, major adverse renal or cardiac events in the 90 days after COVID diagnosis. This was defined using typical terminology as a composite of acute kidney injury, acute MI, angina, stent occlusion thrombosis, stroke, TIA, congestive heart failure, or death. And then, like we've done in previous papers, we also examined secondary outcomes, including the 90-day risk of MACE, acute kidney injury, death, or hospitalization. Our analysis was done separately in a non-immunosuppressed or immunocompromised cohort and in the solid organ transplant cohort. And within each of those groups separately, we examined the proportion of males and females with and without sex-specific HRT exposure in the preceding 24 months, with each primary and secondary outcome in the 90 days after COVID. And then we also looked at the risk of HRT exposure for primary and secondary outcomes separately in males and females after COVID-19 diagnosis, using multivariable Cox proportional hazard models or logistic regression as appropriate. Finally, we conducted several sensitivity analyses, including requiring HRT use to occur in the 6 months preceding COVID diagnosis rather than 24 months, restricting adults to greater than or equal to 55 years instead of 45 years, thereby increasing the likelihood the populations actually represented menopause or andropause status. Examining 90-day outcomes restricted to a cohort of patients who were in hospital at the time of their event. So the event had to occur while someone was hospitalized. Examining 30-day outcomes instead of 90-day outcomes. Given the known association of COVID with venous thromboembolism, but also estrogen HRT with venous thromboembolism. We examined the risk of a VTE, like a DVT or a pulmonary embolism, in the 90 days after COVID diagnosis. And then we looked at in female patients on sex-specific HRT. We excluded those on progesterone monotherapy, given the fact that progesterone is not as well understood to impact the immune response. Finally, we did propensity score matching because we know that transplant patients are typically a lot higher risk in terms of their comorbidity burden, their age, and other factors than the general population. So we performed a propensity score matched analysis using logistic regression with one-to-one matching for SOT status or solid organ transplant status. And we matched on comorbidities, age, sex, race, and SARS-CoV-2 variant period. And we repeated our primary and secondary analyses in this propensity score matched cohort of solid organ transplant and non-immunosuppressed individuals to again examine the association of HRT exposure with each primary and secondary outcome. Okay, our results are shown here. So at the time of our analysis, we had a little over 6 million total patients with SARS-CoV-2 included in the N3C. After relevant exclusions, including our study time period, people less than 45 years of age, those who were non-immunosuppressed, we were left with a study cohort of a little over 2 million patients. And you can see here that there's a breakdown of the non-immunosuppressed cohort or non-ISC of 1.99 million patients and 29,066 solid organ transplant recipients. You can see the breakdown by male and female patients, and in brackets, the people who are on on hormone replacement therapy. So in the solid organ transplant cohort, 322 or 1.8% of patients of males were on testosterone supplementation. And in the solid organ transplant population, 813 females or 7.1% of the population were taking some form of either estrogen or progesterone supplementation. Our baseline characteristic table is shown here, and I'll just orient you and then go over a few key points. So we have in this column the overall number. In this column, I don't know if you can see my arrow, but non-immunosuppressed or immunocompromised males. Beside that, non-immunosuppressed or immunocompromised females. To the right of that, solid organ transplant males. And to the right of that, in the farthest right category column, we have solid organ transplant females. So you can see the breakdown for hormone replacement therapy. Again, just highlighting what I've just told you, that 322 transplanted males were on testosterone supplementation and 813 transplanted females were on either estrogen or progesterone. And of course, because of privacy rules with N3C, we weren't able to go into detail about this any further. When we look at solid organ transplant organ type amongst the patients with the transplant, you can see, which is not surprising, that the majority of patients were made up of kidney transplant recipients with similar distribution between males and females who were transplanted. Comorbidity burden overall was similar between males and females in the non-immunosuppressed cohort, and then separately in the solid organ transplant population. But what you'll appreciate almost immediately is that the comorbidities, not surprisingly, were substantially higher in the transplant patients than in the general population. Immunosuppression only applies to the transplant population because by definition, we excluded any patients in the non-immunosuppressed cohort who are on immunosuppression of any type. Again, the point here is that there's overall similarity between the males and the females in terms of the immunosuppression they were prescribed. In terms of the variant period for when COVID was diagnosed, again, similarity between the males and the females in the non-immunosuppressed cohort and the males and the females in the transplant cohort. But what you can appreciate is that the non-immunosuppressed cohort presented earlier, more commonly in the pre-Delta period, and the transplant recipients developed their COVID diagnosis later on in the pandemic, with the majority presenting during Omicron. And then correspondingly for vaccination status, you can see fairly similar rates of vaccination between males and females in both cohorts, but a higher proportion of transplant recipients being vaccinated prior to their first diagnosis of COVID-19, partially because of a lot of push amongst transplant programs to ensure immunosuppressed patients were vaccinated, but also obviously because they presented later in the pandemic and had more time to be vaccinated. Okay. In terms of event rates, so these are all 90-day event rates, our primary outcome was MARS, or major adverse renal or cardiac event. And not surprisingly, you can see a significant increased risk amongst transplant recipients versus what was observed in the general population. And there was a significant higher risk of each of these outcomes in the transplant population. than in the general population. This is a bit of a complicated slide, but I'll try and walk you through it. So this is amongst females only. The blue bars represent non-immunosuppressed or immunocompromised patients, so essentially the general population. The yellow bars indicate the transplant population. The solid bars indicate patients who are not on hormone replacement therapy, and the thatched bars represent patients who are on hormone replacement therapy. So in these females, what you can appreciate from looking at this figure is that the blue bars, or the non-immunosuppressed cohort, have a lower proportion of all outcomes than the solid organ transplant population. Additionally, within the non-immunosuppressed cohort, you can see that there is a significant reduction in each of these events in patients who also were on hormone replacement therapy, as indicated by the asterisks. So hormone replacement therapy in the non-immunosuppressed general population was associated with less of each of these events. In the transplant population, though, what you see is really a very similar risk, which is high, whether you're on hormone replacement therapy or not, with no significant p-values for any outcome. Amongst males, you see the same trend. So in the blue bars, the non-immunosuppressed cohort, you can see a significantly lower risk of each of these 5 events in patients who are on hormone replacement therapy versus those who weren't. And in the yellow bars, representing solid organ transplant recipients, you see fairly similar risk of each of these events, whether or not the patient was on hormone replacement therapy, other than a reduction in the risk of hospitalization and less death in patients in solid organ transplant males who are on hormone replacement therapy. Okay, this is our primary result, or kind of the main part of the paper. So looking at hormone replacement therapy in patients with COVID-19, to orient you, we're looking here at the risk in females and males separately, and we're looking at the risk of hormone replacement therapy versus no hormone replacement therapy, which is our reference category. Looking at this, you can see again for these 5 outcomes, MARS, MACE, acute kidney injury, mortality, and hospitalization, clearly there is a significant reduction in each of these 5 outcomes with hormone replacement therapy versus no hormone replacement therapy in males and females. So this was fairly novel and built upon the earlier study looking at reduced mortality, specifically with hormone replacement therapy only in women. But to add to this, when we look at the solid organ transplant population, what you see is, again, a pretty striking difference. So you can appreciate here, again, the pink bars are solid organ transplant females, the blue bars, solid organ transplant males. And again, we're looking at hormone replacement therapy versus no hormone replacement therapy. And you can see what we hypothesized, an attenuation of benefit with HRT. So again, the confidence intervals are a lot wider because the population is obviously a lot smaller. But again, the point estimates are right around 1 there. And in some cases in some cases greater than 1. So the only evidence of benefit is in males, specifically for the outcome of acute kidney injury or mortality, where there seemingly was a significant lower risk of each of these events in males who were on hormone replacement therapy versus those who were not. So we wanted to do a number of sensitivity analyses to make our findings a little bit more robust, given the limitations I mentioned about sample size. So this is the same analysis, again, looking at hormone replacement therapy versus no hormone replacement therapy, but instead of using HRT exposure in the preceding 24 months, this is looking at HRT exposure in the preceding 6 months. And again, you see very clearly in the general population, reduced risk in males and females who are exposed to HRT versus those who aren't, except loss of significance for the outcome of acute kidney injury. Again, in the solid organ transplant population, you see fairly identical results. However, in this situation, the only significant reduction in risk was, again, amongst males for the outcome of mortality. So less mortality in males on HRT than males not on HRT. So when we restrict our cohort to adults 55 years of age and older, rather than our initial analysis, which is 45 years of age and older, again, you see similar findings. In the general population, a significant reduction in risk for males and females for every one of these outcomes. In the solid organ transplant population, very similar to our primary findings, reduction in risk in males for the outcomes of acute kidney injury and mortality only, and no benefit for females with HRT versus no HRT. When we looked at outcomes amongst only those patients admitted with COVID-19, you can see substantial, again, in the general population, substantial reduction in risk for the outcomes of MARS, MACE, and mortality. And we've lost that signal of significance amongst for the outcome of acute kidney injury in patients with hormone replacement therapy versus without. And for solid organ transplant population, again, the only significant benefit was in males with HRT versus without, and the outcome of mortality. We've looked at 30-day outcomes instead of 90-day outcomes. And again, you see very similar findings in the general population. We lose the benefit of HRT in males and females for the outcome of acute kidney injury, but significant benefit for all other outcomes. And again, in the solid organ transplant population, you see significant reduction in risk of mortality in males on HRT versus not on HRT, but that's the only signal. And I do want to highlight that the point estimate here, the hazard ratio is 0.37 for mortality in males on HRT versus without. Obviously, the confidence intervals are wide, but certainly it bears more consideration. Again, we looked at venous thromboembolism risk because we were worried that there's an increased risk of VTE with COVID, but also with estrogen and other hormone replacement therapy. But we didn't see any increased risk. In fact, we did see reduced risk in females who are on HRT versus not on HRT in the 90 days after COVID diagnosis. We looked at the combined exposure of estrogen and or progesterone. So that was our primary analysis. So the pink square shouldn't change at all from what I showed you for the primary analysis. But then we also wanted to look at estrogen only, hormone replacement therapy, and that's what's shown in the green bars. And you see that they align really nicely in both the general population and in the solid organ transplant population, suggesting that probably the main driver of these findings is the estrogen and not the progesterone, which is what we hypothesize based on what's known in the literature already about the immune effects of estrogen and progesterone. Finally, we performed the same analysis, or same primary analysis, but after propensity score matching, because as I showed you, there's substantially higher the transplant population is a substantially higher risk population than the general population. So we matched these patients 1-to-1 with the solid organ transplant patients. So the thatched bars or the transplant population doesn't change at all here. It's the same results I showed you right at the beginning, where there's a reduced risk of acute kidney injury and mortality in males with HRT versus without HRT, but not in females. And just to highlight for simplicity, the findings in this matched analysis, you can see that for the outcome of MARS, there was a reduction in risk for females and males with HRT. For the outcome of MACE, a reduction in females only. For the outcome of AKI, no significant reduction in either males or females in this propensity match cohort. For mortality, reduced risk in males on HRT, and for hospitalization, reduced risk in both males and females with HRT use versus without. Okay, well, let's talk about why you might be seeing what we're seeing. So to highlight what I've showed you, there were fewer adverse outcomes after COVID-19 in non-immunosuppressed males and female patients on HRT, a number of important outcomes like mortality, MARS, MACE, acute kidney injury, and hospitalization. There was no benefit in female transplant recipients on HRT in any of our analyses, and there was a potential benefit in male transplant recipients on HRT for the outcomes of acute kidney injury and mortality. And I want to highlight the fact that we did so many sensitivity analyses, and ultimately they were all very, very similar. There was no major outliers in any of the sensitivity analyses. They all really kind of supported our primary analysis findings. So why are we seeing what we're seeing? Well, estrogens are immune stimulating, androgens are immune suppressing. So it's like I said early on, that in this kind of post-menopause or post-andropause period, we're giving back estrogens, which are good. They help with focusing the immune response and targeting SARS-CoV-2. And we're giving back androgens, which are immune suppressing, which paradoxically helps with survival because it dampens down that dysregulated cytokine storm and sort of overactive immune response. At least this is our hypothesis. So I think that's why we're seeing such benefit in the general population. But importantly, in the solid organ transplant population, simply by means of being on immunosuppression, we take away the benefit of altering the immune response with hormone replacement therapy. So we see fewer adverse outcomes in the non-immunosuppressed population, likely on account of enhanced immunity in females, likely on account of less dysregulated immunity in older males. Again, these are just our hypotheses, but this is what we predict is going on. And in the transplant population, we hypothesize that immunosuppression is blocking the beneficial sex hormone immune effects Is it possible that small sample size is playing a role? Of course it is. And that's something that needs to be mentioned. However, we see that even accounting for those wide confidence intervals in the transplant populations, the point estimate is very close to 1 for a lot of the cases. So I'm not convinced that that's what's driving our findings. There are a number of important limitations that bear mention in addition. So all systemic estrogen supplementation was examined together, despite known potential differences in absorption between oral and transdermal formulations. We had no information, or we didn't include information regarding changes in immunosuppression or differential therapies used in managing outpatient or hospitalized COVID patients. We do know that transplant patients are considered at higher risk, so it's possible they got more prompt or aggressive care early on in their COVID diagnosis. Our observation window begins at the time of a positive COVID test. So this current study cannot comment on the potential risk of acquiring SARS-CoV-2 infection in those with or without hormone replacement therapy exposure. And importantly, there has been some earlier literature talking about the fact that testosterone may actually upregulate viral entry into cells. And so that's not captured in this study. Our population was restricted to those greater than or equal to 45 years of age, which is a little bit younger than probably what peri or postmenopausal status is. We do not have access to measured sex hormones. It's possible that patients not taking exogenous HRT still had very adequate endogenous testosterone and estrogen reserves that would attenuate the relative benefit observed with HRT. So if we could prove that these patients were post-andropause or post-menopause, it's possible our signal would be even greater. Our analysis was repeated in those greater than 55 years of age and didn't show a substantial difference. And really, this would not be expected to differentially impact solid organ transplant recipients and the general population. This study does not account for patients transitioning gender. We define sex-specific hormone replacement therapy as estrogen or progesterone in females and testosterone in males. So that's a separate question that certainly warrants investigation. There was no knowledge of HRT discontinuation prior to COVID diagnosis, and we do know that cessation of HRT can lead to an increased risk, a period of increased risk. We didn't have that information available to us. And then, of course, there's always potential for unmeasured confounding, and association obviously does not imply causation. We tried our best to work around this. We propensity score match, we adjusted in multivariable models, but of course, that's always a possibility. So what about impact on the field? So sex-specific HRT is associated with better COVID-19 outcomes in older non-immunosuppressed males and females. The benefit of HRT in transplant recipients with COVID is limited to less AKI mortality in transplanted males with no benefit in females. This is the largest study by over an order of magnitude to examine sex-specific HRT in males and females in the general population. And it's the very first and to date only to examine HRT use in solid organ transplant recipients. And I really think that it provides further support to the hypothesis that the mechanism of benefit from HRT in male and female patients with COVID is likely immune mediated. In terms of future study, is it possible that there's a role for a trial of testosterone therapy in males with COVID-19? This is certainly outside of my wheelhouse, but it's something to consider. There have been a number of earlier trials, this one published in 2022, looking at sex hormone supplementation or the role of sex hormones, but in fact, rather than giving supplemental testosterone, looking at anti-androgen therapy, because early on, and what's discussed in this paper as well, we know that males have a higher risk of worse outcomes after COVID-19 diagnosis. And so the thought is testosterone must be bad because males have worse outcomes. But in fact, I think in reality, it's not so much that testosterone is bad and that leads to bad outcomes in males. I think it's more so the relative benefit observed in females is on account of estrogens being beneficial. So perhaps future direction could include an RCT of testosterone versus placebo in non-immunosuppressed males with COVID, or an RCT of testosterone versus placebo in solid organ transplant patients with COVID, because we did see that benefit in terms of acute kidney injury and mortality. And we're only talking about 322 patients who were included in this study who are on HRT, male transplant recipients who are on HRT. And of course, in any observational study, there's all sorts of risks of confounding. So we might see a stronger signal in an RCT. So in summary, female patients are lower risk for adverse outcomes after COVID-19 than males, and sex-based COVID risk is much attenuated in solid organ transplant recipients versus what's observed in the general population. These are findings from our earlier N3C-based papers that was published last year. The benefit of HRT in the general population is very strong, but it is much attenuated and in fact absent in solid organ transplant recipients, who attenuated in males and absent in females. And ultimately, this supports the role of sex hormones in COVID-related immunity and risk. The benefit of HRT is mitigated in solid organ transplant recipients due to immunosuppression. Again, this is just our hypothesis, but this is what I believe. So I'd just like to thank Dr. Rosalind Mannon, who's the leader of our SOT group in the N3C, and Mr. Alfred Anzalone, who's been very helpful with all of our analyses, as well as the other co-authors and all the collaborators, many of whom I see on this call. And absolutely so appreciative of the National COVID Cohort Collaborative. This has been such an outstanding opportunity to work with this team and see this program develop, and I'm so utterly grateful for it. And then, of course, my local nephrology division. And with that, I would be very happy to take any questions.
Great. Well, fantastic talk. Thank you. Are there questions? So I have a question, or at least some thoughts. So it's very interesting that HRT is helpful in both females and males. The effect in females doesn't seem terribly, surprising in the sense that during even the beginning of the pandemic, there have been people who hypothesized, obviously, that estrogen could be important in this, and I'm sure there's been research on that. But in males, it's kind of interesting. And so one of the things I was kind of wondering what your thinking might be is, might it be in terms of who gets prescribed HRT? I mean, and this is true with both genders, obviously, but since and I'm not an expert in these things, but my understanding is that estrogen, percentage of estrogen, goes up as men age. And, might it be that one of the things that's happening is that that the relatively, that certain men are going to have a higher rate of increase in estrogen as they age, and maybe those are the ones who tend to get HRT. So that what you're really actually seeing is not so much the HRT. This is just a wild conjecture, but actually these men happen to have higher estrogen, which is protecting them. It's kind of, but I have no idea how you test such a thing other than actually doing progesterone and estrogen levels in a broad set of people exposed to COVID-19, which I can't imagine how you could afford. Do you have you thought about that, those sorts of effects?
I don't, and in fact, I hadn't thought about that at all, but it's a very good point that you're making, that we do know that as men get older, their estrogen levels can go up, not everybody equally, but estrogen levels can go up, I think, still to a far greater level than what's observed in females. So I don't think it's probably playing a massive role, but it certainly could be playing some role. But I think the bigger issue is exactly as you highlight, that not everybody gets HRT, and there's clearly a risk for confounding by indication, in the sense that or confounding by indication, like why are people getting HRT, but also the population that gets HRT are typically those without cardiovascular disease or other issues, because of these concerns about increased risk of cardiovascular disease or municipal embolism in these patients. And so I think that I'm not sure about the estrogen piece. It's a really good question. It's something that certainly should be looked into. But I definitely think that there is a difference in the populations who are getting prescribed HRT versus those who are not, because of concerns regarding risk or contraindication. And we didn't really pull that apart in this study.
Great. No, this is fascinating data, and I mean the fact that it's extremely thought-provoking and lead to a lot more research. Let's see. So we have a bunch of texts. Wonderful presentation. I agree. Andrew Williams, Ken Wilkins agreed. Kudos on taught compelling work behind it. Amanda, and then Andrew Williams says, Joel, I think there's a confounding by indication issue that propensity score matching should take care of. If preference scores were roughly similar in the HRT and non-HRT groups. And sure, I mean, absolutely. One is trying to do the propensity matching, and I'm sure it's done correctly, but it's as you say, you never really quite know what you don't know. But it's intriguing. Do you know offhand whether in other infections you see similar sorts of impacts of HRT? Is it only COVID, or you may not know that, but is it something that's been documented with other diseases?
So it's not well studied, actually. And because when I wrote the paper for the discussion, I really wanted to tease apart the literature and obviously highlight areas where this would have been done before. It's really not well understood in the literature, and there's not a lot, at least not good quality evidence, that HRT impacts other viral infections. And it's especially relevant in the transplant population, where people are very high risk of CMV and all these other viral infections that are fairly similar. They're very different, but they have some similarities to COVID-19 or SARS-CoV-2. We do know that that females and males react to different viruses differently. And I don't actually know if there's been age stratified analyses to kind of support whether there could be a sex hormone piece there.
Yeah, no, it's an interesting question. Okay, so any other thoughts, comments? Well, very, very thought-provoking talk, for great data, really fantastic work. And let's see, am I missing? I don't want to end before.
Joel, sorry, I have one last
question.
question.
Really wonderful. Thank you so much. We really enjoyed it. I just wanted to, nice job.
Thank you so much. I appreciate that.
Sam, were you trying to say something?
I was just, it is interesting, and yeah, really appreciate the thoughtful presentation and the work. And I guess, are you considering any further research into this for different diseases? I think that would be, obviously COVID was by itself, but I agree with what Joel was saying. It's really interesting, especially on the male side. So I'm just curious if there's follow-ups or next steps on other disease types, other diseases.
There hasn't been to date, because the N3C is so unique in the data and the granularity of the data that's available for studying SARS-CoV-2. And so our other existing transplant registries, they do not have this degree of granularity, or it would be impossible to study this with our existing databases. Although within the N3C, I know that there is kind of growth of the data that's available. And so I'm not sure, to be honest, I'm not sure. We have not thought about it, but it's a really important question, I think. And it just hasn't been possible until now with the N3C.
No, thank you for that. And I think it's something we're also obviously doing work here at NCATS and the N3C community of how we could broaden it beyond just COVID. So, just really appreciate the work you and your team put into this. Really, it's very, obviously it was, outstanding work, but great to see the outcomes. And honestly, things that many of us, I never would have thought of this as a research topic, going into it. There's such a broad area, but just to hear that the data itself is what makes it possible. So how do we expand it? Thank you again for presenting tonight.
And it is impressive in terms of N3C and the granularity of data that you were able to dissect those populations, because obviously solid organ transplants, while not numerous, are getting that level of granular data on a population of solid organ transplant patients who also have COVID is very, very, very much, I think, a testament both to your team's analytic capabilities as well as the nature of the N3C environment.
Yeah, thank you.
I'm sorry.
Oh, I was just going to say that I think absolutely, just a plug for N3C, like this would not be possible with any other existing registry or database to date. So I think it's such a privilege to be able to work with this data.
So Carolyn Ramonte wants to know, did you see an interaction with BMI by any chance? But asking just as adipose tissue is hormonally active.
So we actually didn't look for an interaction with BMI in this study. I'm trying to think if there was an issue early on with our analyses where we had a lot of missing data for BMI, and I can't remember if that was applied to this study or if that had already been fixed by this study, but we didn't look at an interaction. It's a really good question. Thank you for that.
Yeah, interesting thought.
Amanda,
all right.
I'm sorry. Yeah, just one quick, I'll be quick. Amanda, so Sam Michaels was commenting that we're trying to plan for beyond COVID. If you had a wish list that would make a source of data wish list that would make, that we would link to, like we've linked mortality and things like that. We are pursuing two large repository registries. One is SEER, the cancer registry, and one is SRTR, which is the transplant registry. But if you think of one or had one on the top of your head, please let us know. Be very interested.
Thank you. I think that I had heard informally that there was questions about linking to the SRTR, and I am so incredibly excited if that becomes a reality, because as a kidney transplant doctor, the opportunities are literally endless with data like that. There is such a wealth of studies that can be done. So the SRTR is really the main one, I would think.
Oh, thank you. Sorry, Joel, I didn't interrupt.
No, that's fantastic. No, that's great. Let's see. And Andrew says WHR might be an even better indicator of adiposity than BMI, but isn't as commonly available.
That's a really good thought. Certainly, I know I don't know if it would be available in the N3C and SRTR. I've done actually quite a bit of obesity research using the SRTR, and no waist circumference available in SRTR. And I'm not sure, haven't looked in N3C. I imagine probably not often that well captured.
I think it'll be available, but not nearly as much as BMI. So it won't be absent, but I mean, I can't cite the numbers, but I think there are some. It's just, if you wanted to do it two ways, one with something slightly more indicative. I thought it was a good idea because of the adiposity association with hormones. It made sense. Just a thought. But anyhow, again, thanks so much for the really fantastic research. Great work.
Thank
Okay.
you.
Great. Yep, go ahead.
Oh, I was just saying thank you for the suggestions. They're good, and we'll consider them.
Okay, very, very stimulating talk. We all very much enjoyed it, and thanks for it. And we'll see everybody in a couple weeks. Take care. Bye.
The invitation. Bye.